I'm going to ask Dr. Gaeta to please turn on his camera now and join us. There we go. And let me introduce Dr. Gaeta to you and turn the program over to him. Dr. Stephen Gaeta is a specialty care physician who is board certified in cardiovascular disease and clinical cardiac electrophysiology. He has a special interest in the management of heart rhythm disorders, including atrial fibrillation, supraventricular tachydysrhythmias, ventricular tachycardia, and premature ventricular contractions. Dr. Gaeta is also part of the multidisciplinary team at the Inova Atrial Fibrillation Center of Excellence, who offers patients a comprehensive integrated approach to treat atrial fibrillation and address all the underlying risk factors that contribute to that condition. Dr. Gaeta received his medical degree from Cornell Medical College. He did his residency in internal medicine at the University of California, San Francisco, and his fellowship in cardiovascular disease and cardiac electrophysiology at Duke University Hospital. Dr. Gaeta serves as the medical director of electrophysiology services at Inova Alexandria and Inova Fairfax hospitals. He is also the director of electrophysiology outreach at Inova, which focuses on bringing needed cardiac care to the underserved areas in our region. He sees patients at Inova arrhythmia offices in Alexandria and Fairfax, and has medical staff privileges at Inova Alexandria, Fairfax, and Loudoun hospitals. At this point, let me turn the program over to Dr. Gaeta, and I will be back at the end to help process some of the questions. Stephen, it's all yours.
All right, perfect. Well, thank you so much, Warren, and thank you, Rana, for organizing this. And most importantly, thank you to all of you for joining us tonight. I really appreciate you taking the time. And I'm always so amazed to see how many people come for these atrial fibrillation topics, but I guess I shouldn't be surprised given how common of an issue this is for so many people and how impactful it is for everyone's lives. But I'm really excited to share with you some of my expertise about treating atrial fibrillation, as well as my enthusiasm for this topic. So just briefly, an outline of what we're going to talk about tonight.
Actually, Stephen, I'm not seeing your slides, so we're going to have to get
Oh, sorry.
there.
Yep. One
Minor
second.
detail. Yep.
My apologies. This will just take one moment. So I was going to start, I'll bring them up here as I talk, with a brief outline of what we'll be going through tonight. So we'll talk about what is atrial fibrillation, the symptoms of atrial fibrillation, its diagnosis, why do we care about it? And then really the majority of this is going to be how can we help and what can you do to help? My experience with these sorts of talks is I really think that the best use of our time together is the question and answer session. So I'm really looking forward to you guys submitting your questions. Typically, we cover a lot of ground with those questions, so please keep them coming. So to start off with, for those of you on the call who have a diagnosis of atrial fibrillation, it's worth knowing that you're not alone. This is an extremely common condition. It's the lion's share of what we treat as electrophysiologists. So 10.5 million American adults have atrial fibrillation, probably a lot more of that. They just don't even realize it yet. I have on the right this figure showing the projected growth from 2010 to 2030. And this is actually some old data where they projected 12 million in 2030, but actually we're blowing way past those estimates. So it's growing even faster than people realized. As much as 5% of the adult population has atrial fibrillation, and the majority of that, 70%, is in patients who are 65 to 85 years old. So an extremely common condition. Not surprising, there's a lot of people interested in learning more. So atrial fibrillation is an electrical disorder. A lot of you will know a lot of this from your own medical history or some research you've done, but I wanted to go through what atrial fibrillation is, really from a pretty simplistic level to make sure that we're on the same page as we talk about the treatment options. So AFib is an electrical disorder where there's rapid and irregular activation of the top chambers of the heart, the atria. Atrial fibrillation is triggered by extra heartbeats that come from irritable heart muscle in those top chambers, and it causes the loss of the normal contraction, the squeeze of those top chambers of the heart. So going through in more detail, this is kind of a cartoon that I like to draw for my patients in clinic, so forgive the lousy artistic skills. But when we talk about atrial fibrillation, we're really focusing on the left atrium, the top left chamber of the heart. So if this is the left atrium of your heart, that's what drains the blood from the lungs, shown as those gray blobs in the background, back into the heart through the veins on both sides of that top chambers, those little tubes. The blood then goes down to the main pumping chamber, the left ventricle, that squeezes it out to the rest of the body. So your heart knows when to beat normally because there's a wave of electricity that goes through it. That's what tells all the cells in your heart when it's time to squeeze. And that's what we're measuring when we take your EKG. So what happens in atrial fibrillation is that there's some irritable heart muscle that starts firing off some extra heartbeats, some extra sparks of electricity. Most commonly, they're coming from those four pulmonary veins in that top left chamber of the heart. There's just some very irritable sleeves of tissue in those veins that, for a variety of reasons, is very prone to causing atrial fibrillation. And what happens is when you have those extra sparks of electricity, they break up that normal smooth wave of electricity into a chaotic and disorganized mess, where the electrical signals basically swirl around in all different directions. It's like a little electrical thunderstorm in the top chamber of your heart. When this happens, as I said, it makes that top chamber go very fast, irregular, and it stops squeezing. It just kind of quivers in the top chamber of the heart. One of the main consequences of atrial fibrillation is that because it loses that contraction in the top chamber, the efficiency of your heartbeat actually drops. It doesn't work as well as a pump as it should. And that's where a lot of the symptoms of atrial fibrillation come from. The symptoms can be very, very widely varying. I would say that the majority of the patients that come to see me complain of things like palpitations, feeling their heart rates racing, skipping beats, fatigue, shortness of breath, definitely the most common symptoms. Sometimes for more severe atrial fibrillation symptoms, you'll see people who have dizziness. Rarely they can even pass out. Atrial fibrillation is almost never an acutely life-threatening problem. It's not something you're going to drop dead from in a rapid way, but it is something that can cause a lot of chronic symptoms and can cause some long-term health consequences, as we'll talk about. It's amazing how widely these symptoms can vary, though. You have patients who have very severe symptoms, but then actually about 15 to 30% of patients, they have no symptoms at all. So sometimes called silent atrial fibrillation. And I'll admit, I think this number is probably an overestimate. Most of the time when patients come in saying they have no symptoms of atrial fibrillation, it's often that they've just been in AFib for so long that they've gotten used to the symptoms and they don't realize that they actually are having some symptoms. The best example of this is all the time in my clinic. Patients come in having been in AFib for a very long time, and they say they have no symptoms. But when I get them back into normal rhythm, they say, actually, I guess I wasn't quite as old as I thought I was. Their fatigue gets a little bit better, their energy levels higher, their breathing's a little bit easier. I would also venture to say that if you took almost anybody who's in atrial fibrillation and really put them to the test on a treadmill or other kind of exercise testing, you would find that the efficiency of their exercise tolerance is really a lot less. So a very common problem to have symptoms, and even when people say they have no symptoms, many times there's really something going on there. One of the important things to know about atrial fibrillation is that it's a progressive problem. It gets worse over time. Those episodes that I mentioned where the heart goes out of rhythm and you have this chaotic activation in the top chamber of the heart, they can last for minutes or days, or they can just keep going until somebody does something to stop it. Most of the time, patients start with episodes that come and go on their own. We call that paroxysmal atrial fibrillation. As AFib continues, though, the more AFib you have, the more your heart gets beaten up and changes to want to stay in atrial fibrillation. So the natural course of atrial fibrillation is that these episodes tend to get more frequent, longer in duration, and eventually you get stuck in atrial fibrillation, what we call persistent atrial fibrillation, where it's not going to stop on its own. So to give you a sense, we consider persistent atrial fibrillation to be AFib that's continued for more than a week. And long-standing persistent AFib is continuous atrial fibrillation that goes on for more than a year. So we oftentimes meet patients early on who have a lot of symptoms when they're paroxysmal, coming and going. They very easily can say that they're feeling bad some days, not on other days. But for patients who have more minor symptoms, more subtle presentations, many times by the time we meet them, they're actually already in persistent atrial fibrillation. And it's worth understanding that this progression makes it harder to treat. I'll go through why that is, but all of our treatments are much more effective the earlier in this process that we start giving them. And the longer you have AFib and the more persistent you are, the more health consequences that you can have. About 1 in 5 patients per year, about 20%, will progress from paroxysmal AFib to persistent AFib. And that's one of the goals of our therapy, is to stop that progression to prevent those long-term health consequences. So I want to throw in some pictures as we talk here from our actual clinical procedures. So to show you what I'm talking about and how the heart changes with AFib. So this is something that I'm sure most of you have not seen before. This is a 3-dimensional model of the left atrium of a real patient. So it's the real version of that lousy cartoon I just showed you. This is made with some of the computer systems that we use when we're doing ablation procedures, as I'll describe later. And it's an accurate model of that top left chamber. So this is showing the top left chamber with those veins on both sides. This patient actually has 3 on their right side and 2 on their left. Those are the veins that drain the blood from the lungs back into the heart. And this image is shown color-coded by how much electricity is at each point in that chamber, with purple being normal, healthy tissue, and red being no electrical signals. It's normal in this case to have the red come in as you go further out in those veins. That's where the heart muscle ends and the vein tissue begins. So this is a normal, healthy heart. This is what it looks like when we bring somebody to the electrophysiology lab for an ablation when they have early paroxysmal atrial fibrillation. It's a healthy heart. It doesn't want to be in atrial fibrillation. But the longer you have AFib, the more it starts to change. So this is an example of a persistent atrial fibrillation patient. We oftentimes see things like this, where when we measure the electrical signals in the same way that I just showed you for that other patient, in this case, we see all those colors arising everywhere, which is an indication of abnormal electrical signals in those areas. So we call this a lot of things. We call it scar tissue, fibrosis, sometimes like to call it wear and tear when I talk to patients. But what it is abnormal tissue that's arisen in part because of the continued presence of atrial fibrillation. And the reason why it's relevant is that as you start to have this abnormal tissue throughout those top chambers of your heart, the atrial fibrillation becomes a problem of not just one area, those veins that we can really easily get after, but starts to become a problem of irritable tissue everywhere. And it's much, much harder to treat at that point. So just kind of a visual representation of how I think of paroxysmal transition into persistent and why it really matters. So as I mentioned, atrial fibrillation is an electrical problem and it's diagnosed electrically. So we see atrial fibrillation by measuring the electrical signals of your heartbeat with EKGs. EKGs can come in a variety of forms. The most standard is what we call a 12-lead EKG, a 10-second snapshot of your heart rhythm taken in a clinic. Many of you have had these done before. But we can look for longer periods of time at your heart rhythm by applying external monitors. These are these days little stickers that we apply onto your skin that can measure your EKG for up to 30 days, looking for atrial fibrillation or other heart rhythm issues. We even have longer ways of measuring your heart rhythm, like internal EKG monitors. These are things called implantable loop recorders or ILRs, where we can actually insert a small device the size of a few matchsticks underneath the skin of the left chest that can measure an EKG for as long as 3 or 4 years and automatically alert us if you're having heart rhythm issues like atrial fibrillation. And then finally, there are patients out there that have implanted cardiac devices that are permanent, pacemakers, defibrillators, things like that. They're continuously recording electrical signals from your heart and can actually automatically alert your clinic even while you're at home if you're having atrial fibrillation episodes. So shown on this screen are just some examples of some real EKGs from patients. On the left is the normal rhythm of a patient where you can see those bigger spikes are the activity in the bottom chamber of the heart, but in front of each one is a small little bump, which represents the electrical activity in the top chambers, the atrium. So normal rhythm, you have a squeeze in the top chamber, followed by a squeeze in the bottom chamber. When a patient transitions to atrial fibrillation, the first thing that you can see is that the rhythm, those big spikes from the bottom chamber, is now quite irregular. It's not marching forward like a drum beat. And if you kind of look at the background, that line that should have a little squiggle in front of each one of those larger ventricular activations from the bottom chamber, now there's no bump in front of each one of those. Instead, there's this kind of noisy, chaotic line going through the background. That's the electrical signals from the top chambers, the atrium, as they fibrillate. They're just swirling around. There's really no coordinated electrical activity, no squeeze from that top chamber. So these days, a lot of patients are diagnosing themselves. And what's great is that most of the time it's actually quite accurate. So how can you do that? Well, there's symptoms, including measuring your own pulse. A lot of people can detect their own pulse being irregular and they come into clinic complaining of that as a symptom. But there's lots of other ways that you can use technology to your advantage. So the simplest for many patients is the blood pressure cuff that many of you probably already have. A lot of these blood pressure cuffs, first of all, they'll give you your pulse and you can detect whether your heart rate is much higher on some days than other days. Your heart rate is varying a lot more on some days than other days. Those could be signs that you're in atrial fibrillation. But a lot of them, including the Omron monitor that I have shown here, have an irregular heartbeat alert, a little icon that comes up if it detects that your pulse is irregular as it's doing your blood pressure. Now, that's not perfect. It's really not an EKG, but it is a good starting point to suggest that something could be going on. To get a little bit more sophisticated, these days there's some home EKG devices that allow you to take your own EKG. One example is a Cardia monitor that's shown in the middle. There's a few versions of it, but the one I have shown there is actually a little credit card that you put your two thumbs on, and it takes a real EKG that it can transmit to your phone. It actually tries to diagnose it on its own, and it does a pretty good job. And what's nice is that you can actually send it to your doctors most of the time through an online portal. At Inova, we use the MyChart system, and very frequently I have patients with atrial fibrillation or with new diagnoses who are sending us their EKGs through the chart for help with interpretation and to confirm what their diagnosis could be. To get even more sophisticated, there's wearable devices. The Apple Watch is probably the most sophisticated. It's also the most expensive. But Apple Watches, Fitbits, Garmin's, there's a variety of devices these days that are actually FDA approved for AFib monitoring. So you have to set them up, but they can tell you if suddenly you have a fast and irregular heart rate. And if you set them up properly, it will give you an alert and can even, if you have a diagnosis of atrial fibrillation, tell you how much of the time on a week-to-week basis you're in atrial fibrillation as opposed to normal rhythm. So a lot of these devices are really complementary for what we're doing in clinic. We're still getting regular real EKGs in clinic to make crystal clear diagnoses, but for patients who either are trying to figure out what their diagnosis is or have a diagnosis and want to know if we're being successful with our treatments that we're giving them, these devices are really critical. And I ask patients to get these all the time. So let's talk about why we care about atrial fibrillation. There's a number of reasons. I've already touched on the fact that it can decrease your quality of life by causing those symptoms that I mentioned. That's a big one and one of the main reasons why we treat it. But there's a lot of other risks that come along with atrial fibrillation. The biggest one that we think about is the risk of stroke. But there's also risks of heart failure, a weakening of the heart muscle because of atrial fibrillation, hospitalizations for these issues, dementia, and other long-term health consequences that go along with atrial fibrillation. The goal of our management of atrial fibrillation is to think about those factors and use our treatments that we have available to improve the quality and quantity of life for our atrial fibrillation patients. And what's really important as people are looking at their doctors, at the systems that they work with, is that treating AFib really needs to be a comprehensive care program and it needs to be patient specific. There's a lot of factors that go into atrial fibrillation, including weight, sleep issues like sleep apnea, diabetes, high blood pressure, many other conditions, and it needs to be a comprehensive approach. And in terms of it being patient specific, I'm going to describe a lot of the AFib that can come up for the average patient, but there are a lot of patients who have AFib that comes from other conditions that go along with it that require really pretty nuanced management decisions. So as we think about treating AFib, these are the goals that I have for every patient that I see in clinic, trying to prevent strokes, improve their quality of life, prevent heart failure, prevent the progression of disease, and reduce mortality. So briefly, let's touch on this stroke risk, because this is really a main cornerstone of what we do. So patients with atrial fibrillation are at 4 to 5 times higher risk of stroke than patients without. AFib is one of the major causes of ischemic strokes, strokes due to a lack of blood flow to the brain. So 20 to 25% of ischemic strokes are due to atrial fibrillation. And that image on the right side of the screen is an ultrasound that shows why this can happen. When that top chamber is not squeezing, it's just quivering, the blood can pool inside of it and form a blood clot. And so this is an ultrasound of the top and bottom chamber of the heart, the left atrium and left ventricle. And what's shown is a blood clot sitting inside of that top left chamber, this thing sitting right here. If that travels out of the heart to the rest of the body, it can cause any number of problems, but the most catastrophic would be a stroke. And strokes from atrial fibrillation tend to be more devastating than strokes from other causes. So this is always on our mind when we think about how we're treating atrial fibrillation. Now, the good news is that in 2025, we've got better options to help with stroke risk reduction than we've had in the past. So treatment with modern anticoagulants reduces the risk of a stroke by 70% or more. So these are things like Eliquis, Xarelto, Pradaxa. We have other ways to help reduce the risk of stroke with things called Watchman devices or other left atrial appendage occlusion devices that actually plug up this area of the heart that's shown in that image so that if a blood clot forms there, it can't get out. We might touch on that in the Q&A session, but I didn't want to get into it in too much detail yet. So this is what we do for the stroke risk, but for all those other aspects of the AFib management, the quality of life, preventing heart failure, and so forth, there's 2 major strategies to treat for that. There's what we call rate control and rhythm control. Rate control is the idea that for some patients, you allow atrial fibrillation to continue, but you just use medications or procedures to control the heart rate to make sure that the heart isn't racing. That can be helpful to help prevent some of those issues and decrease the symptoms from AFib. But far and away in 2025, we prefer rhythm control. Rhythm control is where we actually try to control the rhythm of the heart. We use medications and/or procedures to decrease the amount of AFib you're actually having, hopefully get rid of it entirely, and to prevent those AFib episodes from coming up in the future. In 2025, this is far and away the preferred initial strategy for atrial fibrillation. So how can we do this? How can we control the rhythm of the heart? There are 3 main ways that we can do this. There are more beyond this that we're not really going to touch on unless they come up in the Q&A session, but there's cardioversions or shock procedures, there's medications, and there's the ablation procedure. So touching briefly on cardioversions, a cardioversion is a shock procedure where we get you to sleep for a few moments and give you a painless shock to reset your heart into normal rhythm. It works extremely well to end an episode of atrial fibrillation that's not going to end on its own. The problem with doing that is that it doesn't stop the AFib from coming back. And for patients who have persistent atrial fibrillation that would need this kind of a shock procedure, the AFib will come back at some point. And in order to prevent it from coming back, you need to use either medications or a procedure called an ablation to help decrease those irritable extra sparks of electricity that are going to trigger AFib again in the future. I'm not going to touch very much on the medication approach, the pharmacological approach tonight, because I really want to focus on the ablation because that's our first line treatment these days. And it's really what I specialize in. So I'm happy to answer questions if people have them about medications, but really my main focus is on the ablation. So what is an ablation procedure? As I mentioned, an ablation procedure is a small procedure with the goal of getting rid of those extra sparks of electricity that trigger AFib episodes. So how do we do that? The way we do it is by bringing you to the hospital, getting you asleep with anesthesia, and then putting in some big IVs into the right leg. Through those IVs, I put some instruments up to the inside surface of the heart, and I use them to make a small ring of scar around those veins on both sides of the top left chamber of the heart, the area where those extra electrical signals are usually coming from. Once we have that ring of scar, then the blood can keep flowing through the middle of those tubes, those veins. But those sparks of electricity that trigger AFib can't get past that layer of scar into the rest of the heart and trigger more AFib episodes. So you can see here, this is a real patient that underwent an AFib ablation. On the left is the initial picture of their heart showing the electrical signals, and on the right is after we did the ablation. Those little dots are showing where I did the ablation for this particular patient in a ring around the veins on both sides. So as you can see at the beginning of the procedure, this is a paroxysmal early AFib patient with healthy electrical signals throughout the chamber of their heart. After we've made that ring of scar, you can see those veins are now colored red, meaning no electrical signals are getting in or out of those veins. That's the goal of our treatment for atrial fibrillation, to make sure that any electrical signals from that irritable tissue can't get out and trigger more AFib. A modern atrial fibrillation ablation procedure doesn't look like it used to look in the past. And this is one of the challenges with people looking up AFib online and getting their own sources of information, is that there's some really old or even bad information out there. So these talks like we're having tonight are great because I can update you on the modern state of atrial fibrillation ablation. So these days, an AF ablation procedure is an outpatient procedure, same day discharge. It's about an hour or less for the initial procedure. There's a very low risk of a major complication, less than 1% risk, and there's low or even zero radiation exposure during the procedure. Importantly, there's really minimal recovery time. After the procedure, you typically have about 4 hours of bed rest in the hospital, but then you go home the same day. And most people are feeling fine that same day, perhaps a little groggy from anesthesia, but really on their feet, walking around, doing normal things, and back to their normal life within a day or two. So it's a pretty small procedure to go through and very safe. It's worth touching on the ablation technologies that we have now that we didn't have in the past. So as you start to research this online, you're going to see this come up a lot, pulsed field ablation. So I wanted to touch on what that is and why we're so excited about it as a field. So traditionally, AFib ablations have been done using either heat energy to create scar by cauterizing the tissue, that's radio frequency ablation, or cold, using cryotherapy that makes scar tissue by freezing the tissue. There's been all kinds of other techniques invented along the way that have been kind of left by the wayside, lasers and all kinds of other stuff. But the newest technology that we're all very excited about in the last couple of years is this pulse field ablation. So it's another way to make scar tissue in the heart, but as opposed to using heat or cold, this is the catheter that actually applies a very strong electric field that causes this nearby cells in the heart to scar. The reason why that's really good is that it actually is able to specifically target heart muscle cells, not the adjacent tissue that we don't want to impact with our ablation, the esophagus, nerves, coronary arteries. A lot of these areas that could be collateral damage, we no longer have to worry about as we do this ablation. It's made it a much safer procedure. It's a faster procedure. And because it's not causing as much irritation to the tissue as these thermal approaches, the heat or cold caused, it's actually a much easier recovery for patients as well. It's a very, very exciting technology. There's some early signs that it may be more effective than the other ablation techniques as well, but we have to stay tuned because this has only really been in full force in the last couple of years. But it looks very, very promising, and it's a big part of what we're doing these days. So quickly, what can you do to help? Atrial fibrillation goes along with a lot of other lifestyle factors. So really the best things that you can do to help would be kind of normal, healthy living type things. So maintaining a healthy body weight, controlling your blood pressure, controlling your diabetes if you have it, those sorts of things. Smoking, I'm sure as you can imagine, it's not good for a lot of aspects of cardiovascular health. It's the same for atrial fibrillation. Alcohol is actually directly irritating for the heart. So I do recommend that everybody try to decrease their alcohol if they have atrial fibrillation. I actually would not consider caffeine consumption to be a really big factor for AFib unless you're really having excessive amounts of caffeine. Typically speaking, normal amounts are not such a big deal. And then if you have AFib, any kind of stress on your body or your mind can actually trigger AFib episodes. So oftentimes people who have AFib, if they have other illnesses going on at the same time, they'll have an AFib episode in conjunction with that. So really it's kind of healthy living and controlling all your other medical aspects. So that's most of what I had to say. I just want to briefly touch on the services that we have to offer at Inova. So Inova is recognized as an AFib Center of Excellence. This is a definition defined by our professional society, the Heart Rhythm Society, and it's based on the fact that we have a comprehensive approach to care. So when you see us in the AFib Center of Excellence at Inova, you're actually getting plugged in with weight loss medicine, sleep medicine, and a number of other specialties that can help us to make sure that we're controlling your AFib from all angles at once. We have a lot of resources online. If you go to inova.org/AFib or /AFib Center, you're going to see a lot of great information that's up to date, including videos from myself, my partners, a lot of great information and resources, as well as some contact information to help you see us in our clinic. So that's most of what I have to say. I'm really anxious to hear all of your questions. I'll leave up some contact information here as we talk as well. But Warren, if you're ready, I'm happy to start hearing what people have to say.
Absolutely. That was a lot of information and beautifully presented, Dr. Gaeta. And we're going to have a lot of questions and send them in. I'm going to try to keep up with folks, but obviously a lot of questions are circling around ablation. And let me try to put them in some sort of an order, but let's just go back because you said, and for the folks out there, the pendulum really has swung. It didn't used to be that ablation was the first line therapy. And you told us now that most electrophysiologists are seeing that as first line, for atrial fibrillation. But who is eligible for ablation? If you have a first episode of atrial fibrillation, it's paroxysmal, it lasted an hour or two, you were in the ER, you went back into normal rhythm on your own. Is that someone who's eligible for an ablation, or do they have to be symptomatic? I mean, so how is that defined?
That's such a great question. There's sort of two questions there. One is the question about how early you should be considering this sort of approach. And the second is how much do symptoms impact that decision making? So as I mentioned in here, AFib tends to get worse, not better over time. And the earlier you intervene, the more successful we are with these treatments. So if you have somebody who has paroxysmal atrial fibrillation, this early form where it's coming and going, doing that one procedure, the catheter ablation procedure, has about an 85 or 90% chance of being all you need, that one procedure, to keep you out of AFib for a number of years, hopefully get rid of it entirely. If you wait till patients are in persistent atrial fibrillation, when they've made that progression, the chance of one procedure being all you need drops to maybe 60, 65%. And the reason is that it's hard to know where you're going to need to put the ablation for someone like that who has persistent AFib, because it could be a problem from a lot of different areas inside of the heart. So the earlier you intervene, the better. But the question is, how early is too early? I would say that if you've had one episode of atrial fibrillation, that's too early. We should give it a shot to see how long you go, maybe address the other lifestyle factors, weight loss, sleep apnea, and so forth. And hopefully you can push it way back. Or if you intervene on some of those lifestyle factors, maybe it won't even come back at all. There's not a hard and fast rule for how frequent episodes need to be to really consider doing these interventions like an ablation. I would say that if you really want to hang your hat on something, if you're having episodes more than once a year, it's probably very reasonable to start considering this. But realistically, if you're having episodes and it's impacting your quality of life, either the symptoms of the episodes, the anxiety about when the next one's going to happen, or if your symptoms are really severe when you have an episode, all those things would push me to want to intervene earlier rather than later. There's other aspects too. If you have a heart that's abnormal at baseline, if your heart is weakened for any number of other reasons, AFib is particularly bad in that case. It makes a bad situation worse. It can make a weak heart get even weaker. In those patients, we're much more aggressive about trying to control their heart rhythm early and to stop this progression, as we mentioned. Now, the question
Great.
about symptoms, I mentioned, sorry, really quickly, I mentioned about symptoms that
Oh,
if you have severe symptoms, it's going to make me want to treat as early as possible. But the other punchline here is that even if you have no symptoms at all, it is much better for your heart to be a normal rhythm than for it to be an atrial fibrillation because of those other health consequences that come along with it over time: heart failure, hospitalizations, dementia, things like that. So even for patients who have no symptoms, I still recommend we do something to try to control their atrial fibrillation. And as I said, many times you're surprised that in fact they had symptoms they weren't aware of.
Yeah, thanks, Dr. Gaeta. The corollary to that question of ablation becoming first-line therapy is, are you running into a roadblock with insurance companies? Do insurance companies recognize that ablation is first-line therapy now, or do they have different criteria that they go by?
So we really don't have any issues with insurance coverage for AFib ablations. We would never do the procedure if a patient wasn't covered by insurance because that'd be unrealistic, unfortunately, in the United States. And typically, I have no issues whatsoever having patients approved. And that's because AFib ablations have already been shown to be much more effective than medication approaches, as well as cost effective. So the insurance companies are actually aligned with us on this, which is great.
And last question, just sort of about indications. Is there an upper age cutoff?
It's a
If
good
I'm
question.
90 degrees and 90 years old and symptomatic, am I still a candidate?
So age is just a number. It's much more about frailty or lack of frailty. So that's the first thing to say. I have patients who are in their upper 80s and early 90s who look fantastic, where if they needed some sort of help like this, I'd be very happy to do it. The other thing is that our willingness to do this procedure on any number of patients has changed as the procedure's gotten safer and faster and more effective over time. So the statistics on the safety of this, as I said, less than 1% risk, that's much better than it was 10 years ago, 15 years ago. And it means that we're willing to do this for patients who are getting higher in age or have other medical issues going on and things like that. I would say that the vast majority of the patients that we're doing this for probably less than 80 years old, but these days we're doing a lot of patients well into their 80s as long as they're healthy and not particularly frail.
Yeah, let's move. I'll probably come back to ablations again because there are so many questions, but let's talk a little bit about anticoagulation. All right,
Sure.
you said that one of the major complications of atrial fibrillation is stroke, and to reduce that risk, we put patients on blood thinners, on anticoagulation. People always ask us, do I need to be on anticoagulation forever? If I've had an ablation, can I stop my anticoagulation?
It's a great question. And I can tell you what the current answer is, but I'll also say that we need to stay tuned because there's lots of research into this question. So it might change over the next couple of years. The way to think about the question about anticoagulation is that we don't make the decision about being on a blood thinner and anticoagulant based on whether you're in AFib right now or not. It's based on how high the risk of a stroke is if the AFib comes back. Unfortunately, there is no such thing as an absolute cure for AFib. Even with an ablation, medications, anything at all, there's always a risk it will come back. And so we typically make the decision about being on a blood thinner or not based on how high your estimated risk of a stroke is. So if your estimated risk is very low because you're younger, you have fewer medical issues, then there are many patients who do not need to be on a blood thinner long term. But a lot of patients, we recommend continuing them as a just in case strategy. The good news is that the blood thinners we have available these days are very safe. So as an example, Eliquis, the risk of a major life-threatening bleed from Eliquis is about the same as a baby aspirin. It's not zero, but it's not nearly as high as most patients think it is. So they're very good medications to be on, very safe and extremely effective for reducing that risk of a stroke.
You know, patients sometimes hear this mentioned and don't understand what it is. Do you want to talk about what a CHA2DS2-VASc score is? Because that
Yeah.
pertains to the calculated risk of stroke, right?
Yeah, exactly. So, a lot of times in medicine, the way that we try to figure out patients' risks for things like stroke is we gather tons of data together from hundreds of thousands of patients, and we see who had strokes and try to identify what features of their health predicted the fact that they were going to have a stroke, what these patients have in common. And what's been found over the years is that there's some other medical conditions or demographic features that go along with strokes and atrial fibrillation. So these are things like congestive heart failure, high blood pressure, being over the age of 65, or even more so being over the age of 75, a history of diabetes. If you had prior blood clots, like a stroke in the past, that's another risk factor. And then if you have other vascular disease, like coronary blockages or blockages in your arteries in your legs, those sorts of things. Being a woman is also another risk factor for having a stroke in AFib. So typically speaking, you put all those together and you end up with a risk score that goes from basically 0 up to about 7. And if you have one of those risk factors or zero of those risk factors, it's worth a discussion about whether you should be on a blood thinner, but there's not really necessarily a right answer. If you've got more than one of those risk factors, then most of the time the answer is the risk of a stroke is high enough with atrial fibrillation that it makes sense to be on a blood thinner, and even as a just-in-case strategy, as I mentioned.
Yeah, we didn't touch much upon, unless I missed it, folks who just can't take anticoagulation for any number of reasons. And maybe if you could just touch upon Watchman as a procedure, as an alternative to anticoagulation. And well, I'll start with that and then come back to the other part.
Sure. So a Watchman device, I sort of alluded to it quickly. It's a very simple idea. It's a little plug that we can put into the part of that top left chamber where blood clots usually form in atrial fibrillation. It's an area called the left atrial appendage. It's a little sac sticking off the front of that top left chamber. The idea is that if you put that plug there, then patients, if they have a blood clot inside of it, it can't get out. It's a very common procedure these days. There's also a lot of research going into who the right patient to have this type of procedure would be. And you'll find a lot of different practice patterns on this amongst physicians. Typically speaking, the most clear indication for this type of a procedure would be a patient who has a high risk of stroke, but also can't be on a blood thinner. So you need a way to reduce that risk of a stroke that doesn't expose them to the risk of the blood thinner. These are people with histories of bleeding in the past or other conditions. Those are patients where I think we all feel very comfortable saying that they should have one of these devices put in, one of these little plugs. There also are patients who end up with these devices because of other circumstances. And you can actually find a lot of physicians who will implant these just based on a preference against being on blood thinners. I'll tell you that's not the usual practice at Inova. We typically are reserving these for patients who can't be on blood thinners. And the reason for that is that it's hard in 2025 to say, based on the data that we have available, that these devices are as good at reducing your risk of a stroke as a blood thinner. And in general, we want you to be on the most effective stroke risk reduction strategy possible. So for the majority of patients, we're still prescribing blood thinners and not going down the road of a Watchman.
Yeah.
But this is a very rapidly evolving area, and things could change as we get more studies that are coming out.
Yeah, absolutely. And would you ever consider doing an ablation on a patient who can't even be on short-term anticoagulation following the procedure?
So
Is that an
unfortunately,
absolute no-no?
yeah, unfortunately, to do an
Right.
ablation, you really need to be on a blood thinner for a short period of time before and after the procedure. So if you have an
Right.
absolute inability to take it, it kind of rules out an ablation. There are other treatment strategies we can do, like those rate control strategies to slow the heart down, but realistically, an ablation is kind of off the table at that point.
And sort of, I want to try to come off the ablation thing, but and there was a good question about another alternative. Someone who's had multiple ablations and just has failed multiple ablations
Right.
and continues to have, I'm going to say, symptomatic atrial fibrillation. Is there anything else we can do for them? And I'm setting you up for AV nodal ablation.
Yeah. So I'm going to get to that, but I think actually I was waiting for this question to come because let's talk about why people might need more than one procedure. I touched on it a little bit during the presentation as well. When we do an AFib ablation, the common question people ask is, how do you know where to ablate? And the short answer is that we can't tell you for you specifically where that irritable tissue is that's causing your AFib in most cases. So when we do an AFib ablation, it's a statistical approach where we say, I don't know where your specific issue is, but for 85 or 90% of people, it's those veins in the top left chamber of the heart. That means that if people have more AFib after an ablation, most commonly it's because there's some other areas that are contributing to it. But the only way to know if all you need is that pulmonary vein isolation procedure that I showed you is to do it and then see how things go. You can always add more scar in the future with additional ablations, but you can't take it back. So we take a graduated approach for this. So it is unfortunately still common for patients to need more than one procedure, but that's especially true for patients who are later in AFib, the persistent atrial fibrillation, where it could be coming from a lot of different areas. So the short answer is that people have had multiple ablations for atrial fibrillation and are continuing to suffer from the symptoms or other issues associated with AFib. The first thing is that there are newer technologies and techniques available, and sometimes the right answer is to try another ablation technique to see if you can get at it. Sometimes you can switch to medications or a combination of ablation and medications to try to control the rhythm. But what Dr. Levy is referring to is that some patients, we really do get to the point where we're not able to stop the AFib from happening. It's getting less and less common, but it is a thing that can arise. When that happens, we really need to control the heart rate, and there are medication ways we can do that. But another somewhat common way to handle that is to use a pacemaker to help control the heart rate. Now, this is a hard concept to really explain, but a pacemaker, it actually can give you extra heartbeats when your heart is going too slow, but it can't take away the atrial fibrillation. Common misconception. So the way that it can help with atrial fibrillation is actually we combine it with a small ablation procedure. And the ablation procedure we do is not one where we're trying to get rid of the atrial fibrillation. What we're doing is we're actually cauterizing on the normal wiring of your heart that connects the top and bottom chamber. That way, even though the top chamber is in atrial fibrillation, going very fast and irregular, the bottom chamber, the main pumping chamber of your heart, which is really what you feel, it doesn't know anything about what's going on in the top chambers. And what you do is you implant a pacemaker before you do that so that the heart rate is set in the bottom chambers by the pacemaker. Now, what's really awesome is that just like there's been lots of advances in atrial fibrillation management, pacemakers have changed dramatically in the last 5 years. And the ability to put in pacemakers that give you very natural heartbeats has really expanded in the last couple of years. So this kind of a technique is becoming more common in some ways, or at least more ideal than it used to be. When we implant a pacemaker now, you have a very natural heartbeat. I will say though, it's still kind of the last stop on the train. It's not our preferred treatment strategy because it's really not getting rid of the AFib itself, and because we're implanting a permanent device, obviously.
Along those lines, does anything rule out you doing an ablation if someone already has a pacemaker, if someone's had a heart valve surgery, if they had bypass surgery? Is there anything, in a patient's cardiovascular history that would prevent you from doing an ablation?
You're going to find some exceptions to this. There are always patients who have some things going on that maybe I'm not coming up with right now, but for the most part, all the things you just listed are really not an issue. So bypass surgery, that's the coronary arteries, that's on the outside surface of the heart, we're on the inside. Valves, many patients who have valve issues or have had valve replacements, actually that goes along with AFib quite a bit. So we actually treat those patients very, very commonly. So yes, there are patients with, unique cardiovascular issues that would preclude an ablation, but it's many fewer than there used to be. And for the most part, we can get it done.
I'm not going to get off this topic. I just think it's important to also mention atrial fibrillation's cousin, atrial flutter.
Yeah.
So I wanted to know, oh gosh, can you also do an ablation for atrial flutter? And is it more successful, less successful, or, equally?
Yeah.
Yeah.
That's a great question. So these two things are best friends, atrial flutter and atrial fibrillation. 40% of people who have one will have the other. Okay. And they're very similar. In atrial fibrillation, the electrical signals of your heart are broken up into a chaotic and disorganized mess. In atrial flutter, those same extra beats that can put you into atrial fibrillation, instead, they break up that smooth wave of electricity and they let it get caught up chasing its own tail, going around something inside of the heart. It's like a little racetrack. For most patients, it's going around the valve in the top right chamber of the heart. That's called typical atrial flutter. Just like with atrial fibrillation, it makes your heart go very fast. You lose the normal squeeze in the top chamber of your heart. The symptoms and the reasons we care about it are almost exactly the same as atrial fibrillation. So a very similar and related condition. The good news about atrial flutter, it's extremely treatable with ablation. I actually don't even have any conversation about medications for the most part with patients who have atrial flutter because the ablation is so much more successful than medications in that case. Part of the reason why is that I've sort of alluded to the fact that with atrial fibrillation, I can't say for a specific patient where exactly their AFib is coming from. It's more of a statistical approach. For atrial flutter, I can make maps and pictures like what you saw earlier in the presentation and show exactly where that electrical signal is getting caught up, going around, chasing its own tail. So I can find that circuit that's going around and make a small wall of scar across it. It's like building a wall in a racetrack. Once you do that, the rhythm stops and goes back into normal rhythm. And for atrial flutter, for the majority of them, it's actually a curative procedure. So if you have atrial flutter, definitely we're thinking ablation. If you have atrial fibrillation and atrial flutter, which is a common scenario, we would treat both at the same time during the ablation procedure.
Thank you. A couple of questions about the relationship between atrial fibrillation and dementia. And I don't know if there's a direct cause and effect, but is there anything you can say about that relationship?
There's not much to say because you're right. There's not kind of a
Yeah.
mechanistic direct cause and effect there, but there is a correlation, right? And so it's one of the reasons why we think it's important to help control atrial fibrillation. But beyond that, I can't say, that if you get rid of the atrial fibrillation, how much your risk of dementia is reduced, or that it's going to definitely get rid of a risk of dementia. I would never say something like that. It's really just one more feature of the fact that your body doesn't like to be in atrial fibrillation. The blood flow is not normal. Your heart's not working the way that it should.
Hey, so if I come and see you tomorrow and we decide we're going to do an AFib ablation, or any of the electrophysiologists at Inova Heart and Vascular, at Inova or Virginia Heart, is everyone using pulse field now? Am I guaranteed having a pulse field procedure? Or is that something we need to talk about?
So everybody has access to it. Pretty much everybody is. We're really lucky at Innova, excuse me, that we have access to all the latest technologies. So we're really on the forefront of this. We have early access to clinical trials looking at investigational devices. We have early access to the commercial systems that are available. We really have everything at our disposal, which is wonderful, which means we get to really choose for a specific patient what the right approach is for them. I will say for the vast majority of patients, pulse field ablation is the right answer. There are some kind of nuanced things where the systems that are available for pulse field ablation are not quite the right approach yet. These are some things like supraventricular tachycardia, SVT, certain areas of the heart where really this is not necessarily the right way to approach it. But for the majority of AFib patients, yeah, everybody's using pulse field ablation, and that's a good thing.
An interesting question, and I'm going to apologize. There are so many questions. I know I'm not going to get to them all, but I kind of like this one. Why has the number of AFib cases in the population increased so quickly? Or is it that we're just diagnosing it better?
It's both. So in terms of the diagnosis, we're diagnosing it earlier, and oftentimes in patients who are less symptomatic than in the past. If you just look down the street and look at how many people are wearing Apple Watches, you can imagine that we're getting a lot of patients much earlier than we would have seen them otherwise, just because their watch is telling them that they're in AFib. It's not a perfect detection. It's sometimes false positives, as we call it, where it's not real, but many times it is real. And that's a really good thing that we're meeting these patients earlier. There's also just a much greater recognition amongst physicians as well as patients that this is something that we need to be thinking about, that you shouldn't sit on this for many years before you send them to a specialist. So we're seeing more and more of it. But then, of course, as you see in a lot of aspects in America, the health of the general population has to do with this too. So this goes along with obesity, which is obviously an epidemic in America. So we're seeing more and more AFib as obesity has increased. And as the population ages, we're just seeing more AFib as well.
Yeah, thank you. I'm a huge fan of wearables, and I didn't think I would be 10 years ago, but I'm sure both of us have had patients come in and they've made the diagnosis for us because they recorded a heart rhythm at home. Um, but a lot of patients get a little confused about any kind of heart rhythm irregularity, and they think it's atrial fibrillation. So can you talk just briefly about premature atrial and premature ventricular complexes and how
Sure.
that can make your heart feel irregular, but you're not in atrial fibrillation?
Yeah, exactly. So the way that these devices typically screen for atrial fibrillation is they're looking for irregularity in your heart rhythm. But AFib is not the only reason your pulse can be irregular. So a lot of times the false detections that we're seeing are patients who have an individual extra heartbeat that makes their pulse irregular, but it's not atrial fibrillation. So premature atrial contractions are individual extra heartbeats from the top chamber of the heart. Premature ventricular contractions, or PVCs, are individual extra heartbeats from the bottom chamber of the heart. Both of those are a common cause of false positives from those monitors. It's the reason why, if your Apple Watch, as an example, says that you may have AFib, it's always good to follow it up with a real EKG from your Apple Watch and then bring it in to show your doctor or send it to them.
Yeah. You talked about some of the lifestyle things that can predispose. One of the questions that has always come up, and I think it's been negated, are things like certain medications like decongestants, caffeine, coffee. Are those triggers for atrial fibrillation? Or as
So,
some also asked about exercise. If I exercise too much, can that
yeah.
lead to AFib?
So I'll start with the exercise one because it's important that I want people to understand that you should continue to live a healthy life even if you have AFib. And for the vast majority of patients, exercise is not a trigger. So listen to your body. If you're in AFib, it's still safe to exercise. Just slow down if your body tells you to slow down. And don't be afraid to exercise if you have a diagnosis of AFib because it's so important that you continue to do that. There are rare people, typically high performance endurance athletes, that can get AFib at a younger age, but that's sadly not the majority of us, including me. So I wouldn't worry about the exercise as much. Caffeine has been studied more in the last couple of years than previously. And as I mentioned, caffeine at normal intake levels of caffeine is really not a strong trigger of atrial fibrillation. It's really more the alcohol that is the most common offender in terms of what people are taking in.
Do you want to give a 30-second on holiday heart?
Yeah, so holiday heart is a, a cute term for when young people come into the hospital because they're having atrial fibrillation. And it can be triggered just when you have somebody who's young and otherwise healthy who just drinks way too much alcohol, can have an episode of AFib just because of the alcohol. Those patients, typically the AFib will stop on their own, and they many times will never have AFib again after you tell them you've just simply drunk too much.
And it's when your alcohol level's falling, not when it's going up, right?
Yeah,
Yeah.
exactly. So oftentimes it's the next day kind of thing.
Right. A couple of questions about maze procedures. People wanted to know, like, well, if someone told me maybe I should have a maze procedure for my atrial fibrillation, what is it and how does it compare to what you guys do?
Yeah, great question. So a maze procedure is a surgical technique. So where a cardiothoracic surgeon, typically with open heart, open chest procedures, will make lines of scar inside of the top chambers of your heart. And they're making that scar. In the past, it was by literally cutting the tissue and sewing it back together. Nowadays, they use catheters, kind of like we do, to make the scar. The idea is very similar to what we've talked about, is making walls inside the heart that the electrical signals can't get past. Nowadays, maze procedures are very, very rarely done in isolation. It's a very uncommon patient that we would send for a maze procedure on its own. They are very commonly performed, though, in patients who are having open heart surgery for other reasons who also have a history of atrial fibrillation. So if you're getting a new valve put in or a bypass procedure and you have a history of atrial fibrillation, the surgeon will very commonly do a maze procedure, making those lines of scar, and they'll also typically occlude that left atrial appendage. They'll kind of clip it off so that you also reduce the risk of stroke. So that's where we're usually seeing it. One of the reasons why we're not doing maze procedures as much as in the past on their own for AFib is that it's really conceptually the same thing as what we're doing with catheters. We're making lines of scar inside of the heart. And doing it with a catheter is a much smaller and more easily tolerated procedure than going to a cardiothoracic surgery.
Yeah, I'll take the catheter and not the knife. Thank you very much.
Yeah, exactly.
Couple of quick questions. The question of, is aspirin as good as anticoagulants for atrial fibrillation? People always ask that.
Unfortunately, aspirin does not do a lot to reduce your risk of stroke from atrial fibrillation. So the decision really is, are you on a real anticoagulant or are you not on anything?
Yeah, and I have another one because this is really misunderstood. And I think you and I both see physicians who will take patients off of blood thinners because they say, well, they're a fall risk. And is the risk of falling and having some sequelae from being on blood thinners worse than having a stroke from taking them away?
Yeah, so that's the most common reason for
Yeah.
people inappropriately stopping blood thinners, anticoagulants. And it's something that we really need to work as a medical community to try to stop. The benefits of a blood thinner for atrial fibrillation are so great that you would have to fall 290 times a year for the risk of falling to outweigh the benefit of the blood thinner.
Right.
So for the vast majority of patients, that's really not a reason to stop it.
And that is something we really do need to get out to the medical community. Several questions about sleep apnea. First was, which came first, the chicken or the egg? Did the AFib give me sleep apnea, or did sleep apnea give me AFib? And I know in the past, there are some electrophysiologists who made patients get evaluated for sleep apnea before they would consider doing an ablation. How strong is that correlation?
Well, there's correlation and there's causation. The correlation is very strong. If you look for sleep apnea in patients who have paroxysmal early atrial fibrillation, you'll find it in as many as 75% of patients. So we see that correlation very frequently. Now, part of it's that these two travel in the same circles, right? Obesity, other medical issues, they can cause atrial fibrillation, they can cause sleep apnea. Atrial fibrillation does not cause sleep apnea. That's one direction that I can say very confidently is not happening. But if you have a history of atrial fibrillation and then you have sleep apnea, it can trigger AFib episodes. The reason being that when you have sleep apnea, it means you stop breathing at night for periods of time. When that happens, the pressure builds up inside of your lungs, it backs up into the heart and it stretches it out and irritates it. And you fire off a lot more of those extra sparks that can put you into AFib. So common correlation. There are some patients where sleep apnea does trigger episodes, but the AFib does not trigger the sleep apnea.
Yeah.
Oh, and to answer your question, we, as part of our AFib center, we send many of our patients to get sleep studies based on some screening questionnaires to see whether they have sleep apnea because it is such a common diagnosis to find for them.
You know, you brought that up. We'd only have a couple of minutes left, but can you just briefly touch upon the Atrial Fibrillation Center of Excellence is not just seeing an electrophysiologist. What other services are involved with the AFib Center of Excellence?
Yeah, so the main services that are involved would be weight loss medicine as well as sleep medicine. So the weight loss medicine is really wonderful because losing weight is one of the most effective lifestyle interventions you can make for atrial fibrillation. And in 2025, there's lots of great weight loss options that weren't available before. We've all heard about Ozempic and Mounjaro and those sorts of things. So very commonly, patients who are overweight, if they're interested, we have them see our sleep medicine doctors either on this, excuse me, our weight loss doctors either on the same day or soon thereafter. It's a much faster way to get into a weight loss clinic than if you were just coming off the street. Likewise, with sleep medicine, as many of you probably know, the wait list for a sleep study can be very long. But once you're in the AFib center with us, it's very straightforward for us to get you to see the sleep medicine doctors and have a home sleep study or a facility sleep study, depending on what's indicated.
And that's a great segue to what may be my last question here. It's talking about the GLP-1 medications, the new weight loss medications that are all the rage and are probably being given to a lot more patients who really are indicated for those meds. But in terms of atrial fibrillation, have the medications themselves helped you in managing atrial fibrillation, or is it just the pure effect of weight loss, less sleep apnea, better control of diabetes and hypertension?
I think it's more of the latter, but another way to put that is that the weight loss that you get from these medications is real weight loss, and it comes along with all the cardiovascular benefits that weight loss from any mechanism has. So I don't know there's anything special electrically about these medications with treating atrial
Right.
fibrillation, but the weight loss effect is just profound, and it's helped a huge number of my patients. It's really fantastic.
That's great. Dr. Gaeta, this has been absolutely spectacular.